सेशन में कंटिन्यू कर रहे हैं. लैपटॉप
Greetings from Team Indian Medical Association and IMA Access. Welcome to our show, weekly show, and that's a weekly webcast on one of the important subjects. And this we do every Thursday, 3 to 4 p.m. With me is Dr. V.K. Monga, who will be moderating the session. And congratulations to Dr. Monga for having taken over as the Dean of Indian Medical Association, College of General Practitioners.
Congratulations.
The whole idea of me and Dr. Monga covering these sessions are so that all aspects, whether it is for a specialist or for a general practitioner, gets covered. And wherever I feel that Monga feels that I am diverting, that it needs to go more basic, so he can interrupt. Because his interest is more for a College of General Practitioners. Today we have an important session, and that important session is heart disease. We focus on congenital heart disease and valvular heart disease. Instead of talking about when to operate, we are talking about when not to operate. Taking a decision to operate is very easy. But next time when you say that whether it was indicated or not. So our focus will be when not to operate. And with me is Dr. Sameer Srivastava, who is a director non-invasive cardiology at Fortis Escort Heart Institute in New Delhi. And he's an expert in non-invasive cardiology in all fields. And we know that the decision to operate or not to operate is dependent on a non-invasive cardiologist. Because we are the one who come back and define and debate, can we postpone, is it necessary to do that, is there a risk-benefit ratio or not. Now this webcast is available on IMA website, and this comes to you every week by the emedinexus.com. And if you go to the site www.emedinexus.com, you should be able to see a live webcast, and in that live webcast you can put your comments and we can also interact with that. You can also ask questions on SMS. Either you can call or send an SMS to 98101 18256, or you can send an SMS to 98110 90206, and we should be able to interact with you during this period. I also bring greetings from my new president, Dr. S.S. Agarwal, who has now taken over as the National President of Indian Medical Association, and who took over from our President, Dr. A. Marthanda Pillai, on 28th of last month in December. And we will also, in the next 1 or 2 weeks, we will also bring him as a live webcast with him to listen to what his ideas about IMA are. So let's go back to our subject, congenital and valvular heart disease. And I'll devote few minutes first to the incidence of rheumatic heart disease and the incidence of valvular heart disease. Sabir, when I was in medical college, we were told rheumatic heart disease is 6 per 1,000. Is it the same, reduced, increased?
Most likely it has reduced, but we don't have the exact data. But if you look at the studies from Nepal or India, it is somewhere around 6 per 1,000. It's almost there. earlier probably the ways it was discovered was based only on clinical practice, but now that echo is available and titers are available, probably the numbers were underestimated in that era, and now with better modalities to discover rheumatic heart disease like echo, we have picked it up, we have started picking it up.
So in 30 years, it has remained the same.
Almost the same.
If I ignore that AIM study which talks about 21,000.
Yes, Dr. Padmavati's study, it was 6 per thousand, but that was a purely clinical study. Here, if you look at it, if you utilize echo as a tool, it will be almost the same. That means it has, if you use
actually reduced, but
actually
because
reduced,
in spite of overdiagnosis, if it is
Right.
6 per thousand, so that
Right.
the incidence is reduced.
incidences.
Is the reduction more in rural or urban areas?
Urban areas certainly it is. We see lesser of it, but rural areas there is still.
So we already have a question from Dr. Suresh Garg. Suresh, we will take up your question a little bit later, and you are talking about in what congenital defect of the fetus we should be advised for MTP. We will cover it up when we come to congenital heart disease. The first portion of that, we want to focus ourselves to rheumatic heart disease. Now, when rheumatic heart disease is common, in our echocardiography practice we see most of the patients coming to us. Now, question comes is when not to intervene. So, in rheumatic heart disease, we'll pick up mitral stenosis, acute versus chronic mitral regurg, aortic stenosis, and aortic regurg, and with the passing remarks to tricuspid valve disease or a pulmonary valve disease because they are uncommon. Tricuspid valve repair is little bit uncommon. Maybe common in CGHS category, but not in a non-CGHS category. Let's come back to mitral stenosis. How do we classify mild versus moderate versus severe? Instead of going into the echo classification or grade classification, we only want people can remember.
Okay. So by and large, initially it was basically, if you remember, the moderates, the mild and the severe will fall into place. Earlier it was 1 to 1.5 was moderate. That means lesser than 1.5 mitral valve area was severe, more than 1.5 mitral valve area was mild. But there has been a shift because we found that most of the people, even with mitral valve area of 1.2 or 1.3, continued to be very symptomatic, and it was purely attributable to mitral stenosis. And these people had a poorer quality of life. That's the reason, if you look at the current recommendations of the guidelines, here the severe mitral stenosis has been graded as lesser than 1.5 mitral valve area. Whether it is by planimetry or whether it is by 3D or whether it is by pressure half time, we are not going to get into
So if I have to remember one number, is 1.5.
Cutoff is 1.5.
So forget about mild, moderate, severe.
Lesser than 1.5.
Less than 1.5, more
patient
than
is
1.5.
symptomatic.
So we basically want to know is less than 1.5 or more than 1.5. How reliable this figure of 1.5 is?
Okay. Even if it is,
if I do an echo, you do an echo, will it differ?
there is a inter-observer variability certainly in echo. But ever since 3D has come, the reliability has become a little better. Because you are exactly cutting off at the place where the funnel is the narrowest. Otherwise, the errors committed in planimetry are that you are not exactly at the place where the funnel was narrowest. And pressure half time has its own limitations. So with 3D being available now at most of the centers, this is a very reliable issue. Second is, more than that, it is the symptoms now. If you look at the current guidelines, everything is symptom oriented. If the patient has got symptoms,
See, I have a little bit concern about symptoms. Because in India, everybody is anemic.
correct.
So there will always be a over reaction because the person hemoglobin may be 9 because of that he is symptomatic and he will be taken up as severe mitral stenosis.
So the symptoms have to be trustworthy, and we should be saying that the symptoms are only because of the valve disease and nothing else.
So should I take it for granted that every patient of mitral stenosis, before we decide the surgery, let's give him 1 gram plus 1 gram of iron, do his iron profile.
Do the iron profile. Appropriate would be
I'm talking about as a
hemoglobin, BC,
now for the benefit of the general practitioners who are watching our program, there was a time when we used to give iron injectable, and we used to give 100 milligram on the first day, 400 milligram on the next day, and then 500 milligram. Yes, Dr. Prachi, please join us. Dr. Prachi is my junior and she handles my echo work in the department. So please join us. And now, and we used to give 1000 milligram over 3 hours every day. And now with the newer irons which are coming, we can give 1000 milligram in 15 minutes.
15 minutes.
Almost like bolus. And then we can repeat it after 2 weeks. So
Right.
therefore, can I come out with an Indian guideline? Now, these guidelines cannot be made by foreigners. In India, every patient of rheumatic heart disease, I should make sure that hemoglobin, his or her hemoglobin is maintained.
Right.
Make sure that all the iron
Stores
are finished, so I can give them 1000 or 2000 milligram of iron. Reevaluate after 4 weeks for the symptoms, and if the symptoms are still persisting, I'm simultaneously looking for 1.5 or more than 1 point, and then I'm also looking for a PAP. Pulmonary artery pressure, both on rest and on exercise.
Correct. And I'll go a little step forwards also. Let's get his X-ray test also done, and also look at lung lesions, because India is a country where lung lesions, whether it is tuberculosis or sarcoidosis, it's not uncommon.
Absolutely.
So if
So
you
I
have
must
to
rule out lung
any other cause.
Any other cause.
We have to have that this patient has got symptoms only because of the valve disease, nothing else. Then only it is justified that you operate upon even a moderate.
So rheumatic heart disease, mitral stenosis, valve area
1.5
more than 1.5.
More than 1.5.
Valve
Symptoms
area,
only
valve area more than 1.5. Asymptomatic.
asymptomatic.
Or asymptomatic after giving iron bolus 1 gram, it becomes asymptomatic. With normal pulmonary artery pressure on rest and on exercise, does not require intervention.
Does not require intervention, but certainly requires
Follow.
penicillin prophylaxis.
Obviously, penicillin prophylaxis is a must in every case of
That's-
that.
that's-
So it does not require any intervention, can be followed up.
How often you give
Okay.
penicillin
Even in pregnancy.
prophylaxis nowadays?
Okay.
And how often you get it in the market also? That's a big issue.
It's penicillin is difficult to get, but we get it. I mean, with effort you
As many penicillin are required, contact Dr. Kechagawar. Our foundation has enough penicillin we keep all the time. Okay, right away I have 1000 penicillin lying unused.
Okay.
So
But-
anybody who
but I mean,
needs,
any
remember,
substitutes
it's
or
free of cost.
anything-
That's fine.
It's free of
I
cost.
Anything which can be given, I mean, if it is not available in a village or something.
If it is not available, then
Contact Dr. K.K. Agrawal, we post them.
Availability is
We
not
will
an
mail them.
issue.
We will send them by
That
courier.
is what we are learning today.
Yes,
But I mean,
yes,
the whole
yes.
people must
That's
have-
our purpose. That also people who are listening, if they have shortage of penicillin, contact us.
Yeah.
Contact IMA. Till I am there in IMA, contact IMA and we'll dispatch you.
You will get penicillin even after he is not in IMA. Make sure.
Regardless of IMA. The only thing is that if just in case people are sensitive to penicillin, then what to do?
Yes.
That's a different issue.
Then that's different, because then you have to give patients erythromycin or sulfadiazine. Those are very cheap drug, really available. Difficult to get now because it's so cheap.
Yeah.
Otherwise, that's
It's
drug
not
of choice.
commercially good for them.
Bharat, another question has come from Bharat, how to differentiate between VSD and MR in pediatric age group. We will take up congenital heart disease little bit later in the next half. So I'm noting down the questions which has come, and then we will come back for the questions later. So let me finalize mitral stenosis, valve area of more than 1.5, done by 2 people at 2 centers to make it so
More
that
reliable.
more reliable. Two different with other causes of breathlessness ruled out, like iron deficiency, X-ray, TB, and any other asthma or other things, with normal pulmonary artery pressure at rest and on exercise.
That's it.
These patients should be
Left to penicillin.
left to penicillin, including the state of pregnancy.
So is there
Including pregnancy.
the pregnancy.
Pregnancy is a time when people can get recurrence of rheumatic fever. That's the reason they need more protection.
So my next question
Should we go
comes
for
in.
PFT also in these
Yes,
cases?
yes. Asthma should be ruled out. Asthma should be ruled out. But the only thing is, what is the protocol for pulmonary artery pressure on exercise? How much exercise? What protocol we follow?
We usually don't do it. Reason being that it is so difficult to target the jet, especially if it is a mild DR. But the ideal protocol which has been described is that go on a cycle ergometry, keep going.
It's not available.
Which is difficult.
So,
So-
most
so-
of the people will not be able to.
So we are just primarily dependent upon the exercise
GMT.
symptoms.
Exercise
and
symptoms.
Symptoms. And it has very limited role in mitral stenosis. It has certain role in aortic regurgitation, it has certain role in aortic stenosis, but
So we leave it as it is. So we say PAP normal, that means less than 35, valve area more than 1.5, asymptomatic, don't touch.
no,
Symptomatic, touch.
certain.
Okay. When I touch, I have both the options of balloon mitral valvolectomy, or I have valvuloplasty, or I have a MVR.
Okay.
I have both the options in that. So balloon first.
Balloon first.
Balloon first, even if it has to be done repeated again first.
Balloon first.
The balloon is always the first choice.
Now that you have picked up this point of pregnancy, actually if it's a planned pregnancy, then with 1.5, even if the person is asymptomatic, these women should prophylactically get a balloon done. Otherwise, they'll have a problem during pregnancy and more so in labor, especially the second stage of labor and the fourth stage of labor. So
Okay, so
this is the catch.
if there is a pregnancy in any way, I think GP is going to refer it to a specialist and or to a cardiologist. Therefore, make sure that if you are in a borderline valve area, is even if it is less than 1.5 centimeter, they may require prophylactic BMV to avoid any complication during surgery with that. Now, my one question which I want to, so suppose a child is going for, suppose a person is going for a surgery. Okay. Person comes from a weaker, economically weaker section of the society. Balloon is not possible, but calcified valve is there, or other indications are there. I am not sure about post-op care. I'm talking about social determinants of health. I'm not talking about the bookish.
I'm absolutely with you, because your quality is that you come out with what is real world problem. That is your question.
Why I'm asking this question is because I sponsor surgeries. Okay, I sponsor almost one surgery a day at various locations. Right away, I have 7 girls and boys with me where I'm reluctant in getting their valve replaced. They need it. It's ethical, it's unethical not to advise them MVR or AVR. Fund is not a problem because I'm ready to fund.
But post-op is an issue.
But my issue is they come from a deep village of Bihar. And I said, make me talk to your doctor. He says, what? I said, PT, INR. He said, what is that test? That's the only person available. So if the INR is not available, should I insist not doing it? I have lost 2 people.
Yeah,
In the last 1 year,
it's an everyday story.
in the last 1 year, I've lost two such people who vouched that no, get us operated. We will stay in India, in Delhi forever. But within 15 days of surgery, they went to their village. There was no facility available, and suddenly the news came that I fell.
It's a tricky situation, but fortunately,
They can't afford Devigator, they can't afford the.
Okay, if funding is not an issue, Dabigatran is in any case
In any way,
for
valvular,
only
it is not for
it is
valvular.
not for valvular. None of the
Tissue valve, no. You
tissue
can't-
valve has its own life.
You can't.
So 15 years, if the person is 20 years, then again after 15 years or maybe 18 years at max, they'll have to get operated. The practical solution as it comes to my mind is that like glucometers, there are these days coagulometers available, which gives a reasonable INR, which is domestic point of care strip test. And if we educate the person well, that if you are having an MVR done, then keep the INR between 2.5 to 3.5, or AVR if you are doing aortic valve replacement, then keep it between 2 to 3. Then this is commercially available now.
But the people who can't afford, they will not be able to. I'm talking
Correct.
about poor people.
If funding, if we
They
are
are
doing
not
funding
getting
for the
it.
They have
surgery,
a surgery done, but we can't give them the instrument.
actually the cost of surgery is much more than this costs about 12,000 or 15,000.
Only.
Only. But yes, I agree. The strip costs about 100 rupees or so.
That's the thing.
If somebody has to do maybe 2 weeks or 3 weeks or 4 weeks, they'll consume almost about.
Then he has to be intelligent enough to understand the value of the test, number one.
Correct.
And then he has.
No, it's a good solution because
Yeah.
once we are sponsoring, we can give them 12,000 rupees machine.
And
Then
educate
and somebody
them also.
and somebody, oh no, we can give them a source of income. Because he becomes the quack technician of that area and can help others, other patients.
One machine can serve more. One machine can
Why
serve.
can't? See, suppose there are
If there are
in
more
that
than one,
locality,
then
you can help others.
Mhm.
Why not? That's
It's something like glucometers being shared in a diabetic clinic.
okay. We come back to anything, Martis, you want to ask? I like a lot.
Introduce Prachi to the audience.
I just said Dr. Prachi Garg is a ex-major from Army, and she is working with me for the last almost how many years?
4 years.
Hmm?
4 years with me.
4 years with me, and she is assisting me in my medical and cardiology work, and she does all echocardiograms. So I thought of inviting her so that we can also interact. So we come back to mitral regurg. With mitral regurg, I have two situations, acute and chronic, and then I have to have a number. Okay, symptomatic, asymptomatic is one. It's a standard formula. See, on valvular heart disease,
These days, everything is symptom based
it has to be symptomatic in absence of any other cause.
in absence of any other cause.
In any other cause, and PAP normal.
PAP now.
If the PAP is high, evaluate. So normal PAP, asymptomatic,
Ejection fraction is also.
normal ejection fraction, not. And what do you mean by EF? Is it-
EF for a mitral registration or aortic registration, the cutoff would be about 60% because once it starts dropping down to 50% because of a high volume contractility and low pressure.
And how do you, when I say EF means what?
Ejection fraction is the quantum of blood.
No, in terms of, because it's inter-observer variability, inter-machine variability, 2D versus 3D variability.
Okay, now those are issues which you want to discuss.
Yes, but why I'm saying this question is, when I was with Marine Nanda in 1987, way back 30 years back, at that time, they were not doing ejection fraction. Ejection fraction had to be asked because it was separately built.
Acha.
It was not a part of echo.
Okay.
Because this is ejection fraction has to be accurate.
Okay.
Therefore, it is not a part of the normal echo. Then if you want ejection fraction, you have to pay extra for ejection fraction. It's like food. So there was $300 for X-ray, there will be around $50 to $100 extra for ejection fraction. I'm talking about 1987.
We can have it now also.
Why not? Therefore I'm saying it, wherever, therefore I'm saying, when you talk about 1.5, anything critical value, all of you who are in the part of the echocardiography society, you have to come back. You should never give the number 1.5 in a routine echo. In a routine echo, you have to finish 60 echoes in a day. It is impossible. Where it matters, 1.5, 1.4, 1.3, it has to be out of routine echo. You should say that there is a mitral stenosis, mild, moderate or severe, and then if they want exact number, is it 1.5, 1.3, 1.2, 1.5, where you need to know devote half an hour, 30 minutes, 20 minutes.
It takes time.
It takes time. That has to be out of the routine conventional echo. It has to be separately built for. Because that is what the interventional cardiologist is looking for.
That is the thing which is
And
decision.
there I am doing echoes. My all these values invariably will be wrong. Because I have no time to spend. So for me, unless somebody asks me, I want exact mitral valve area,
Correct.
it will always be plus minus.
Because
If somebody tells me,
That is most, all
it's not happened. It
echo
doesn't
people
happen.
are doing,
It doesn't happen.
But EF everybody is giving.
EF everybody is giving, it is never done
Accurate.
properly. It is never accurate. Therefore, I'm saying when EF is so critical, about 60 watt 50, then you have to ask for EF. When you say, I want exact EF, then it cannot be done under routine charges because EF itself will take the total calculation of EF will take equivalent charge of doing the whole echo. So in a routine way,
And
you will always
you have
have.
to use several modalities. You have to use M mode, you have to use 2D, you have to use tick.
So therefore, I have been telling
3D.
all the echocardiographers, and they don't listen to me. I have been telling echocardiography
Which
is like a blood test.
echographer doesn't listen to you?
No, nobody listens. They have kicked me out of the echocardiography.
Anywhere in the country.
They say, I said echocardiography is like a blood test. Do you send a person to go to the lab and get a blood test done? You have to write down hemoglobin,
You have to
TLC,
specify,
TLC.
yes.
Similarly, in echocardiography, you need to specify what do you want. Do you want accurate PAP? Do you want accurate mitral valve area? Do you want aortic valve area accurate? It takes time. So therefore, unless you write down what you want,
Then you have
exactly.
You have
Otherwise,
you have to spend that time extra.
the time extra,
That-
and that extra time
Decision
will never
making
be
number.
will never
You have
be
to spend
accurate.
time.
It will never be accurate. It will only be accurate unless you are specifically asking for. Therefore, I am defining today is the mitral valve area 1.5. So there is a number called 1.5, and that 1.4, 1.6 legally can make a difference. Because if you write 1.4 and if you're not doing surgery, there may be legal implications. And in 1.6, you can say it was 1.6, therefore I did not send for referral. So these are legal implications. The number 1.5 has a legal implication. The number 60 ejection fraction in MR has a legal implication.
It has.
It has a legal implication. Anything which has a legal implication, the test has to be done accurately. And in a routine echo, nobody has time. Nobody has time.
Okay.
Whatsoever you do, it is impossible for people to devote such a time. There will always be fallacies.
No, they are only
There
like
will be.
MR, yes or no. Yes, sir. Most of the people
With
are
that.
doing like that.
So in MR, asymptomatic, if the patient is asymptomatic,
MR is a little tricky situation, sir, because here these days more and more number of people are going towards repair of surgery, repair rather than replacement, because replacement has its own problems in mitral regurgitation. You change a mitral valve, the LV starts to dilate, the posterior, the subvalvular apparatus, the moment it cuts off, your ejection fraction falls down, pulmonary artery pressures start going up after replacement, and most important is the problem of anticoagulation, like you said yourself. So, MR should be tackled when it is repairable, and the best time to tackle that is when it is in moderate stages. Even if a person is going for CABG or something of that sort, if it can be repaired, even for mild MR repair should be done. But not nascent MR, but moderate MRs if there is a justification. The problem is that most people with moderate or even severe mitral regurgitation who don't have any symptoms will never agree for a surgery because they feel they are fine. And that is the time when they start suspecting the medical fraternity. That despite the fact that I am absolutely fine, people are pushing me on to surgery, there must be some other motive for it. But if you follow the book, then moderate MR, certainly if anything more than moderate, if the person is symptomatic, they should get operated. If not, then at least counseling.
okay, again, we need a number. When we talk about moderate, we need a number. 1.5
Moderate.
here,
Most robust criteria
vena contracta.
is vena contracta. You are correct, absolutely.
Okay.
If vena contracta is less than 0.3, it is mild. Vena contracta more than 0.6 is 0.7 is
And more than 0.7 is
severe mitral regurgitation. This is the most robust because we know that because of the entrainment, the color Doppler has its own problem because of LA.
What about size of LA, PFP, and LV size, and diastolic and systolic?
Because mitral regurgitation has a problem because LA in 1/3 can be non-compliant, in LA 1/3 can be compliant, in LA 1/3 can be normal. So in a non-compliant LA, regardless of the severity of MR, the LA will be smaller in size. So these are fallacies, but these small size LAs usually have a higher PAP because it all gets transmitted backwards and the pulmonary artery pressures can be high. So if there is a suspicion of high pulmonary artery pressures, if there is a suspicion that the ejection fraction is falling down, if there is a suspicion that the LA volumes are increasing, even if patient is asymptomatic, they get operated. If everything else is taken care of and is accepted, then patient should sit. I mean, you can safely watch that.
So the number is here is 0.7.
0.7 cutoff for vena contracta.
So we say in asymptomatic person, there is 1.5, here is 0.7. So it's difficult to remember. So can I make it 0.75? Half of 1.5.
Okay. I mean,
See,
the
MS 1.5, there 0.75, half of that. It's easier to make it as a formula.
correct, because this is the quality of Dr. K.K. Agarwal, that whenever he teaches in a manner that everybody understands and remembers it for all time. So, I accept it, absolutely.
For Indian people now, will 0.75. So this is half of that.
Correct.
That is for the area and that is for the vena contracta. That's also an area.
Absolutely.
That's also orifice area.
It is a smiley manifestation of opening, leakage, effective orifice,
Some people,
resistant orifice.
we just follow it, we don't remember whatever he's saying most of the time, but he makes it. That's the issue. He makes it and makes other
Understand
remember
it.
So we come back to quickly to AS, then to AR. Give me the number. Aortic stenosis is common. It can be rheumatic, it can be in the elderly, it can be degenerative, and it can be even congenital. So we need to decide number when not to operate. And similarly, in aortic rigor, which can happen with trauma, dissection, which can be rheumatic, which can be non-rheumatic. Yes, number.
Okay, AS, regardless of how severe aortic stenosis is, if the patient doesn't have symptoms, the current guideline says do not operate. Now again, the issue is absence of symptoms can you trust? Like the way symptoms we couldn't trust, absence of symptoms also we cannot trust, because this is a human nature. Today I am walking for 5 kilometers, I start becoming short of breath, I walk for 2 kilometers, then I say that I don't have symptoms, then I start walking for half a kilometer, then I say that I've got no symptoms and I claim that I'm asymptomatic, then back to toilet and I keep sitting. So what is the truthful absence of symptoms, that has to be decided. But if a person is truthfully asymptomatic with critical AS also, they are not to be operated unless, there are caveats in this also, unless the ejection fraction is falling,
Number.
ejection fraction less than 50%, if the septum is grossly thickened, then it is a reason that you
Number.
should 2.
2.
If
PAP.
PAP is high, then it is a justification to operate, and if there is some other associated lesion that a person is going for, say if he is going for CABG, then it becomes a class 1 indication to operate simultaneously.
What
Otherwise,
about preoperative? If person has a severe AS, do I do a TTV clearance or operation? If he goes into hypertension, he's gone.
correct. Because
We're
critical
talking about non-cardiac surgery pre-op.
non-cardiac surgery pre-operatively, then the debate continues whether he goes in for a emergent surgery or a non-emergent surgery. If it is an emergency surgery, then there is no choice, you have to give a high-risk consent, high-risk permission to go for surgery. But if it is an elective surgery, then please get the aortic valve sorted out before you operate. These are, unless the person is going for a cataract
So
or
for me,
cataract or
so to remember is that because needing a surgery is also like a symptom. It becomes symptomatic.
Needing a surgery is something like a symptom, and even planned pregnancy is something like a symptom.
So pregnancy is like a
Like
it's not
a
a number
symptom.
phenomenon. So it's
You are
like
anticipating
you are
problems.
anticipating complications. If you anticipate complications, you need to intervene. Yeah. Chronic aortic regurgitation is common, can be congenital, often rheumatic, non-rheumatic. Is there a number for?
Okay. Aortic regurgitation, again, asymptomatic. We talk about asymptomatic because this is the subset which causes us the biggest problem, because when a person comes with asymptomatic problem, you are confused whether to push him out for surgery or not, because of these are all surgeries which have got a mortality anything between 5 to 12% surgery in valve surgeries. Now, aortic regurgitation asymptomatic, unless the LV is dilated larger than 7.5 in diastole, you should wait and watch. Larger than 7.5 in diastole, 5.5 in systole. If the pulmonary artery pressures are going up, again it becomes a reason, even if the patient is asymptomatic, or if the EF is falling, then also it becomes a reason for you to get operated quicker, sooner than later, even if the patient is asymptomatic. But the first and foremost is the algorithm starts symptoms, no symptoms, and then you start putting in pieces of ejection fraction, then you start piecing in pulmonary artery pressures, and then you come to a reasonable decision whether to operate or not. Now, we missed on mitral regurgitation acute. You asked me a question and then we skipped on it. Acute MR is a very peculiar situation because this most of the times occurs because of either an infective endocarditis, post myocardial infarction, or sometimes degenerative cardies can also rupture spontaneously. This is the situation where you can't trust your LA volumes, you can't trust, the only thing which you can trust is pulmonary artery pressures and vena contractor sublet. And these are situations where, again, if can be repaired, you should be repairing it, because the problem in acute mitral regurgitation is that the LV is not that dilated or the LA is not that dilated that you can put in an adequately sized valve, because they are small, they are not huge valves. And all artificial valves are stenotic valves, and all artificial valves are leaky valves. So you put in an undersized valve, then instead of mitral regurgitation, what the patient goes home with is mitral stenosis. So this is another problem, that in mitral regurgitation, which is an acute thing, they need intervention immediately if it is significant mitral regurgitation, and what they need as an intervention is preferably go for repairs.
So quickly before I go to the congenital heart disease, we some of the questions will take. A, how to differentiate between VSD and MR in pediatric age group clinically?
Why pediatric age group? It's so
Any age
difficult
group.
even in adults, and that's the reason why you should be
So I use
shamelessly liberal to use echo.
I would say no. I use a stethoscope. The definition of a stethoscope is echocardiography. No, echocardiography is a stethoscope.
Correct.
So use your extension of stethoscope. So use your the probe of a stethoscope, instead of stethoscope, use the probe of an ultrasound and do it. It takes less than 30 seconds. And otherwise refer the patient for the how to differentiate VSD, in what congenital defect of the fetus one should be advised for MTP. That means congenital heart disease. Fetus has a congenital heart disease.
Fetal has a congenital heart disease.
Fetus should MTP be advised as in today's era? No answer is.
Today's era, surgical capabilities in good centers is very good. So unless you are expecting diseases like hypoplastic left heart syndrome, if it is a simple ASD, if it's a simple VSD, if it's a simple tetralogy of Fallot, if it is a simple PDA, certainly go ahead with the pregnancy. There is nothing that precludes you to prevent. Well, if it is a complex congenital heart disease where the switches, the looping is odd, or if you are looking at problems like hypoplastic left heart syndrome, these are the patients where, you see, the problem is that we as doctors have never been taught to leave patient to the mercy of nature. But there are certain situations where you have to be philosophical and you say that this is something where the quality of life for the kid can be miserable despite several surgeries. And these are the complex congenital heart disease and hypoplastic left heart syndromes.
So if there is a complex congenital heart disease or a incompatible congenital heart disease, except for that, please continue the pregnancy, have the child delivered, and if you don't have money, we are with you. We will be there to help you out.
There can be cases where patients have become very, very intelligent nowadays. And if a echocardiographer tells them, or a person who is doing level 2 ultrasound, he tells that lady that your child is going to have this and this and this, then maybe, some of the ladies will like MTP to be done, they will like to be aborted.
Therefore, the education has to be given to the first of all to the gynecologist, because let them relearn that congenital heart disease today is curable. They need to relearn. And they need to relearn when we are discussing when not to operate, and we are talking about here when to intervene.
Sure.
When it comes to pregnancy, we are only saying is if it is a complex congenital heart disease. That means if a person who is doing complex congenital heart disease, if he says in writing, I will not be able to repair it when the child is born, then only intervene.
Okay.
Otherwise, no.
Simple.
And make it very simple. Let the person. Otherwise, gynecologist would not know whether it is complex or simple.
And that patient will be going directly to the gynecologist with that.
So therefore, gynecologist should be able to do that. And today's era, specifically, every girl child, because everybody will say girl child, congenital heart disease, problems, let's abort. So you have to be very, very, very careful about that. And that's the reason that we as a echocardiographer, we are debating that every pregnancy should be tracked. PCPNDT Act should be out, and PCPNDT Act should be out, and every pregnancy should be tracked so that those girls who are having congenital heart disease are not aborted on the ground.
Yes.
That the person may not be able to support the fund.
Correct.
That's the way I look at it. Sachi, you want to add something? Activist.
You'll have to come closer because this may not reach there. Come, speak a bit louder.
So let's go back to, so the rule of thumb for valvular heart disease, everybody who is there, rule of thumb is very clear, symptomatic, asymptomatic.
AR 7.5 comes in again.
Yes, AR 7.5. So 1.5, 0.75 and 7.5. So it becomes a very simple way of formula. So symptomatic, yes. Asymptomatic, debate. Pulmonary artery pressure, normal, no surgery. EF more than 60, here they are at 60 and 50. For mitral valve disease it is 60, and for aortic valve disease it is 50, less than 60 and less than 50. And in terms of numbers, in mitral valve it is 1.5, more than 1.5, less than 1.5. In aortic in mitral regurgitation it is 0.75 as the vena contracta, and in AR it is 7.5 in diastole, the LV dimension. So 1.5, 0.75 and 7.5 becomes a simple way of calculation. And in AS there are no numbers, symptoms or no symptoms. It's asymptomatic, leave it to the nature, because it may be better unless you're talking about pregnancy or a pre-op situation where the risk is more. Let's come back to some numbers in congenital heart disease. Let's talk about two, the acyanotic and cyanotic. In cyanotic, let's have complex and a simple complex, simple. When we were doing MBBS, we were taught complex congenital heart disease has no treatment, and then the acyanotic, simple cyanotic heart disease, you require a formula of 10 months or 10 kg. Today, surgery is possible at every step. Reasonably, it is available. People like us at Samir Malik Heart Care Foundation, we are sponsoring it. Salman Khan is the biggest sponsor of congenital heart surgery, and Rotary clubs are the biggest sponsors. So today, even state government, every state government is sponsoring. They have a fund for 1 lakh for a congenital heart disease of a child. So, but no child in India should die just because he is suffering from a congenital heart disease. There are funds available. I mean, I can tell you that we are not getting patients. People like us, we are ready to sponsor, but we are not getting patients. That means enough awareness is not there. I'm not talking about the patients amongst the doctors. So let's come back to acyanotic heart disease, ASD, VSD, and PDA. PDA, we don't want to debate. PDA is like AS, aortic stenosis. PDA means it's closer.
PDA should be closed.
So PDA should be closed. At the time of diagnosis, PDA should be closed. The surgeon can decide whether it requires by umbrella or by surgery.
Usually these days device closure system.
Device closure is sufficient.
It's sufficient.
It's sufficient.
Most of the time.
So therefore we come back to only ASD versus VSD. Yes.
ASD when not to operate. You see, small ASDs don't need to be operated. Small VSDs don't need to be operated.
So if it is small,
Small,
don't operate. So there has to be a number.
the number is QPQS. Now you calculate what is the shunting out of the left ventricle versus the shunting out of right ventricle. If there is a mixing, say if there is an ASD, so what is happening that pure blood is coming into the left atrium and all of it should pass into the left ventricle. But some bit of it is going into right atrium. Now this has to be a cutoff. If the cutoff is 1.5:1, that means if the right heart is having output of 1.5 times compared to the left side, then this becomes a significant ASD or a VSD which need to be operated. So this is a cutoff. There are certain numbers, so your 1.5 comes in again.
This is what I'm saying. Today, ultimately, everything is revolving around
0.75
multiples of 0.75.
So 1.5 QPQS, that is rule of the thumb for both ASDs and VSDs, that if it is more than 1.5, you operate. Lesser than that, do nothing. Except then in VSD, again, if it's a small VSD which you have left, you have to be careful that this VSD is not leading to aortic regurgitation.
Unless it is complicated.
Unless it is complicated. Whether it is complicated by aortic regurgitation, whether it is complicated by
MI,
infective endocarditis,
myocardial infection, whether it is.
Correct.
If it is associated with something else,
then operate. Otherwise, per se, leave them alone. Small ASD.
Simple.
Again, if it is a large ASD also, sir, if there are, India is a country where we discover the atrial septal defects at the age of 60 years. And then you are debating whether to close it or not. In fact, it is more counterproductive to close an ASD even if it's a large ASD at the age of 60 or 65 years, because the LV is not a prepared LV. The moment you close the aortic, the atrial septal defect, the volume the ASD, the left ventricle has to handle is much larger, and LV is an unprepared LV. So what happens with back pressure? They go into left ventricular failure or per median.
Compensated issue is there.
It is very, you don't jump at an ASD closure at the age of 60 years or plus. You have to be very cautious there.
So we still have time. So I don't think so. We need a lot of time into complex congenital heart disease or in a cyanotic congenital heart disease. If the child has cyanotic congenital heart disease, needs surgery. There's no debate about it. Whether it
If it can be operated.
Unless whether it is one stage or a two stage, let the surgeon decide, or multiple stages, let the surgeon decide. And
would you enumerate what are the causes of cyanotic heart disease? What are the forms?
There are several
Which you
forms,
can
sir. If you want to classify cyanotic heart disease, it is classified into two. One is low pulmonary flow groups and high pulmonary flow groups. High pulmonary flow groups are typically total anomalous pulmonary venous drainage, and low ones are typically like tetralogy of Fallot. Now, tetralogy of Fallot has its own formulary like double outlet right ventricular with VSDPS, like TGA with VSDPS. These are low flow situations, low pulmonary blood flow situation, and the ones like total anomalous pulmonary venous drainage are the ones which are high pulmonary venous group. But fortunately for us, the ones which have got pulmonary stenosis or low pulmonary flow group, they give us lot of time for us to margin, because these are the ones who do not go into pulmonary artery hypertension or irreversible sorts. Like total anomalous pulmonary venous drainage, you leave them alone and very quickly they go into pulmonary artery hypertension, and which becomes an irreversible process. So whenever you have to time a surgery, tetralogy of Fallot or the sorts can wait a little longer.
And can you, you said that small
VSDs.
septal defects, they don't need to be corrected. Do you mean that they automatically get corrected, or they are not required?
VSDs several times will get corrected, and small VSDs or moderate VSDs, if the pulmonary artery pressures are not too high, it is better to observe them till the age of about 9 years or so. Once they don't close after 9 years, then you assess the hemodynamics. Still, if it is 1.5 or 1, then they need to be operated. But there are certain VSDs which will never close off. There are certain VSDs which closes off. So these are the ones which ASDs also. Most children, you would be surprised that most children are born with an ASD, but they quickly close off. Soon after, within weeks, the ASDs close off. But typically, when we look at ASDs, the small ones do not need to be operated, or VSDs for that.
so some social issues. Then before we come back to revision, my first social issue is that I recently have a girl who needs surgery. Okay, all criteria are meeting for surgery. She needs surgery means she needs surgery. 2025, one of the government hospitals puts it on writing. Put a stamp. The date for surgery is 2025. And then they write down, no earlier date is available, consequences explained, they are free to go to any other hospital. Who is responsible for this? Can you give a date?
I think it is.
No, what I am saying is, write down, no bed available, we can't do it. But giving a date is a crime. Because that means when you give a date of 2025, it means patient is not going to die till 2025.
Yeah, you are almost ascertaining survival till.
You are ascertaining survival till 2025. Better is to write down, we have no bed, no patient needs surgery, we can't help, refer to other hospital. But if you give a date of 2025, it is something like a patient of TBM, and you are telling them come back after 6 months. But this is happening. This is the concern. Our concern is this. Second concern was, in a village, how do I man the valvular part? So something needs to be done. At an IMA we are fighting for this, and we are saying all such patients with their dates are not available, they should say refer them to any hospital with a sanction of 1 lakh. The hospital would say for example, AIMS, Sadhajang or anybody, they will say, we will pay 1 lakh, let him get operated anywhere. That's the cost they would have governed if they were getting it done in their own hospital. They should sanction 1 lakh if they can't do the surgery. Let the person go to any hospital and get a surgery done at complex. Let them reimburse. Or let the state government reimburse.
It's a very debatable issue, sir. Reason being that they are giving a date of 2025 to deter the patient, probably.
No, but they're writing. Consequency explained.
Maybe they have a booking till that date.
They cannot have a booking till 2025. Sir, the surgeon will retire before that.
Many of them.
Many of them will retire before that.
Okay, let's, we have.
If there is a unit chief
But then
today,
he is talking only about Delhi or the major.
Okay, everywhere it is the same.
So things must be very bad in district and.
it will be terrible. It will be terrible. Leave Delhi 100 kilometers and things
He is
are
talking
terrible.
about a lakh rupees to be given by the government for that patient. But think of a poor chap in Jalore district who cannot even come to a metropolitan city.
So cyanotic congenital heart disease needs intervention as early as possible. You can do it with one stage or a two stage. A cyanotic congenital heart disease, remember the only word 1.5. Isolated lesion 1.5. If it is more than 1.5 QPQS, that the intervention needs to be done. Now I come back to, if I want to summarize, I come back to 5 points. One is QPQS, two is mitral valve area. The QPQS is 1.5, mitral valve area is 1.5, vena contracta is 0.75, PAP for me is 35, and if I can come, let me see if there's some formula I can fit it into.
Yeah, it's half of 70, no?
Half of 70.
35.
30, no, the half of 75, so let me make it 37.5.
Close to 40. I mean,
No, 37.5, it's a multiple of.
You see, you
And then
find that
EF is 50/60, mitral 50, and aortic 50, and mitral 60. These numbers are important. Again, why I'm asking is because Samir is active in the Echocardiography Society. Somewhere we need to sit and decide. These 5 things have to be the out of routine echo. So somebody should write down ASDC. Okay, advise QPQS. So I should be able to say the patient has rheumatic heart disease, mitral stenosis, advise mitral valve area calculation. I should be able to say we need to have a vena contracta. Here we need numbers. Where we need numbers. Or the person should say, referral person, that I'm suspecting ASD, I need, whether ASD is present or not. If present, I need QPQS. A person should be able to say, tell me is it mild, moderate or severe MR. Simultaneously, I want the exact value of vena contracta. For that, either, now it's debatable whether you want to put it as an extra charges or not, is a separate issue, which I advocate it should be extra charges. Even otherwise, for medical legal purposes, you have to put down what you want. You have to ask, you have to write down, I want exact PAP. So that person can devote time into normal PAP or not.
No, understood, sir. The only thing is that they'll say that.
Nobody will say.
Yes.
When the interventional cardiologist for the same amount would have charged 25,000 rupees.
So
The
what we
interventional
have-
cardiologist will talk about, they will start with 25,000 rupees onwards. That I mean the highest charges, you know how much are there for doing an intervention.
No, that's forget about it. They have no upper limit. The
There are
only-
up to 20 lakhs people charge.
Correct. No upper limit.
But there is nobody in the country who says or exactly telling you that whether this is surgical MR or a medical MR, I would charge this much. Or let us redefine echocardiography for Indians. Let us define as a medical ASD versus surgical ASD. Let us define as a mitral stenosis as a medical mitral stenosis versus a surgical mitral stenosis. Medical MR versus surgical MR. Medical AS versus surgical AS. Medical AR versus surgical.
But that is all echo dependent. I agree.
Echo dependent.
So
Echo criteria, medical ASD.
So we have to have echo which is run of the mill echo and specialized echo. Now, what you are
That's what I'm saying. That's what I'm
subsetting.
saying. I'm only dividing into two. I'm only dividing into two. There is a routine echo, and then there is a. It's like a, see, ultrasound people have come back to level 1, level 2.
Level 3.
Why? No. Level 2 ultrasound is, if you want great detail, go for the level 2. If you want only routine, level 1. So the word level 2 means that you need to check everything, 1, 2, 3, 4, 5. For me, QPQS, MVA, Marina Conductor, PAP and EF are level 2 echo. Level 1 echo is minus these 5 things. Ultrasound people, there was nothing like level 1, level 2 before.
No.
But now when you say you want to detect, this is, oh my God, I need to see everything. Every congenital heart disease.
It takes
I have no time. So they're calling me at level 2.
It takes time.
So only echocardiographers are sleeping, everybody else is awake.
Food for thought for us.
Yeah.
Food for thought for you people. Just summarize and then Prachi summarize. What did you learn today?
I think it was pretty good, maybe not very good for the GPs, but clinicians who are dealing with these type of children, it should be very good for them. But for a GP, I suppose in most of the circumstances, once you hear a murmur or you see cyanosis, you tell the patient should go to a pediatrician. And the pediatrician then refers the patient to a echographer or a cardiologist, or pediatric cardiologists are there, pediatric cardiac surgeons are also there nowadays. But definitely for a GP, the domain should be what KK said. He should remember 3, 4, 5 things. Because once a parent brings an echo to you and asks you, sir, Dr. Sahab, surgery ki zarurat hai ki nahi? Then, most of the time you are not able to say anything, and then again refer to a pediatrician. But I believe this was a good topic for GPs as well, because they should know their limitation, they should know when to refer, and then they should know how to counsel a patient. And especially gynecologists also, they should know when not to let the patient get harassed or panicky just because there is a small lesion in a fetus in the womb. I think that should be pretty good enough.
Prachi?
Then what all I could get it, if there is congenital heart disease, cyanotic, it has to be treated, it has to be operated. If it is PDA, it has to be operated. If it is VSD or ASD small, we can leave it and reassess at the age of 9 years. If it is the size is more than 1.5 or 5, we have to operate it. And if the size is more than 1.5 at any age, it has to be operated. If EF is falling, PAP is rising, we have to operate.
Good. So we have the last 2 questions which has come, and then what are the implications of this toxic air to our heart's health? What precautions we should take? No exercise if the level are more than 300. That's the only precaution you can take. Great job. Great job. Great job with Samir Malik Heart Care Foundation Fund. How many poor patients can we expect to see benefit? 1 per day. 1 per day we are not getting. So at the moment we are ending up with almost like 1 or 2 per week. But we have the capacity to sponsor 1 person per day, and that includes not only congenital heart disease, even valve replacement, even bypass surgery, even stenting. So nobody in India should die just because he or she cannot afford. That's all for today. We thank Dr. Samir for joining us today, and Dr. Prachi for being with us. Of course, me and Dr. Monga say goodbye to you, and we'll come back next week. And next week there will be, as far as this center is concerned, we will be not doing it from the current studio, because both me and Dr. Monga will be in Agra on that day. So we'll be doing it live from Agra, because we all will be there in the Foxy conference, and we'll pick up some of the Foxy panelists from there and do it, and depending upon where we get the availability of a 4G connection. So we'll be live next week from Agra at 3 p.m. on some issues related to women care. Thank you very much. Come back to you next week. Thank you.